Welcome, everybody. I'm Mara Yale. I'm coordinator for this educational series, and I'm going to start with a few slides as we still have a few more people joining us. And I want to give an overview of what it is that we're doing here, and not just today, but in general. So as you know, today we're talking about epilepsy, all the way from diagnosis, or maybe there's something wrong, to all the treatment options. In general, after pediatric stroke or brain injury, there's a potential impact on the whole child's life from childhood into adulthood. And this picture is of the medical establishment helping, but what we're trying to do in this educational series is really take different challenges and opportunities out into the community and into real life, beyond what happens in the acute setting. And as a reminder, what we're offering is educational. If you have specific medical questions, you need to contact your healthcare team to get the answers that you need. And we'll ask you to be mindful of this during the question and answer period. So if you have questions, we invite you to ask them in a general way so that you're not revealing private information about your own family situation, for example. Just to highlight what we've accomplished as an educational program, we've now been delivering content for 5 years. We have almost 40 sessions delivered. All of them are curated on YouTube. The top video has more than 1,500 views. You call in internationally, and we have speakers from many, many different organizations, more than a dozen. And now we've begun sharing this model of education at conferences. So we're using that to make sure these videos are shared as far and wide as possible. And I will invite you to register for upcoming events here and on the next slide. So we're actually ahead of where we usually are in planning our upcoming sessions. So again, scan the QR code or go to this link, which I'll also put in the chat. We're going to have sessions on planning for summer, high school athletes, cortical visual impairment. Our in-person event, Play to Thrive, will be the 3rd annual one, May 11th. So we invite you to save that whole morning through lunch, and then language development in May. And we're also planning a couple others that are yet to be scheduled on TMS and executive function. So we're really excited to have such a robust set of educational offerings, and pass it to Audrey, who's going to offer the parent and advocate perspective today on epilepsy.
Hello, everyone. Thanks for joining us today. And thank you so much to Mara and the team at MGH for inviting me to speak today. I'm really honored. My name's Audrey Vernick, and I'm the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. But my most important role is that I'm the mother of a young man named Bennett who had hemispherectomy surgery to stop epilepsy caused by a stroke in utero. Oops, sorry, modern technology. I had a fairly typical pregnancy. There was a concern about possible placenta previa that at the beginning of my 3rd trimester. However, that ended up not being an issue. And my son Bennett was born late. He was born at about 42 weeks, actually. I had a very challenging labor and delivery, and ultimately a cesarean because his heart rate was starting to decelerate and they were concerned about him. And when he was born, he was blue. He had meconium in the fluid and was whisked off for doctors to revise him. His first APGAR score was actually 2, and his second was 7. And he spent a few days under the bilirubin lights due to some jaundice and had a large hematoma on his head because I'd pushed for so long. It took 2 doctors to pull him out during the C-section, actually. I have heard anecdotally, just from other mom friends I know who have had babies who'd had stroke in utero, that they were difficult to birth. Almost all the mothers that I've talked to about this have had a C-section. This is just anecdotal. Of course, at the time, we didn't know or even suspect a stroke. Looking back, I think he was probably seizing within about the first month of his life. We were told that the weird movements we saw him display were moro or startle reflexes. He also had crying episodes after these startle episodes, and his pediatrician told us that was due to colic. When he was finally diagnosed with stroke and infantile spasms at 5 months, I learned that moro reflexes should typically end by about 2 or maybe 3 months, and that he'd never actually had colic at all. His pediatrician missed a really significant diagnosis for 5 months. And looking back through his records, I saw that she noted that he always had his head turned to the left, probably because he had lost his vision on the left side of both eyes. And when he turned his head to the left, he had more vision in his visual field. And his left hand was always fisted. Those clues could have led us to an earlier consult with a neurologist had they been picked up during his early infant examinations. On Mother's Day, when he was 5 months old, he seized all day long. He cried uncontrollably, although we didn't yet call them seizures because we still didn't know that's what they were. And we soon got him in with an amazing neurologist named Dr. Bello, who's going to appear throughout our story. He was immediately admitted for overnight video EEG monitoring, and that's how we discovered the infantile spasms. There's a distinctive pattern on the EEG that's called hypsarrhythmia. The neurologist also ordered an MRI, which you can see on the right, that showed that Bennett had had a massive stroke in the right hemisphere of his brain. I'm going to show you a short video about infantile spasms, and then I'll tell you a little bit more about it. So that video was created as part of the Infantile Spasms Action Network, which I'm part of with our organization. As they mentioned, it's a very, very subtle type of seizure. It's very rare. It can be hard to detect, but part of our mission, oh, excuse me, it's playing again. Part of our mission in our organization and with ISAN and the Infantile Spasms Action Week, which is coming up, is to teach people how to detect infantile spasms. So parents, clinicians, ER techs, EMTs, preschool teachers, et cetera. So it's really, really important. It's considered a catastrophic epilepsy, and I'll talk a little bit more about it later on. So initially, we were lucky. His neurologist knew what the frontline treatment for infantile spasms was. He actually knew what it was as well right away, which is why we were admitted for 24-hour video EEG monitoring, because it's very hard to pick up seizures on a 1-hour ER EEG, just so you all know that. If you think your baby's having seizures, you really need to be admitted to an epilepsy monitoring unit to determine if there are actually seizures, and it needs to be for at least 24 hours. He was started on Sabril or vigabatrin and ACTH, a steroid, which combined as a first-line treatment for infantile spasms, which did control his seizures for a few months, but by the winter they had recurred. He was also diagnosed with cerebral palsy very early on by his neurologist, probably within a few weeks of the initial diagnosis of stroke and infantile spasms. This really helped us to access services for him, so we're really grateful that he was so proactive with that. If the neurologist doesn't give that diagnosis, it's really, really hard to get those early intervention and physical and occupational therapy services. So he started those services at about 6 months and has continued them throughout his life, which has helped tremendously. Initially, we didn't know if he would ever walk or talk, and one doctor did tell us to be prepared that he would never walk or talk someday. Thankfully, that was not the case, and now we joke that we can't get him to sit down or shut up, but that's parenting for you, right? So after the seizures returned, like I said, we had seizure control briefly, and then they returned by the end of that year. We spent almost 2 years after that trying to control his seizures with multiple different medications and combos. I think we trialed about 8 different meds altogether and many more combinations of meds. And our beloved neurologist, Dr. Bello, on the left here, went to the Mayo Clinic for a fellowship, and he had been urging us to consider surgery for quite some time, but our home hospital kept rejecting the idea. They kept one highly regarded neurologist at that center we met when we brought up the idea of hemispherectomy in particular, or any type of brain surgery for epilepsy. She says, oh, no. We don't even want to talk about brain surgery. There's still a lot of good brain left. But actually the damaged tissue in his right hemisphere was not good brain. It was causing him to have these catastrophic seizures. And that was what was holding him back. So ultimately, we did go to the Mayo Clinic. They quickly determined that a hemispherectomy, actually he had a modified corticectomy or hemispherotomy, if you want to get technical, but a hemispherectomy was the best course for him due to the significant damage that his right hemisphere had already been had from the stroke. They felt that disconnecting the damaged hemisphere would stop his seizures, and it worked. We were incredibly lucky in so many ways, but he should not have had 2.5 years of infantile spasms before getting to surgery. We feel that withholding a surgical option did not allow us to make an informed decision as parents, because we need to have all the treatment options in front of us if we're going to make a decision for our child's health. He had the most drastic form of epilepsy surgery. You can't have a bigger surgery than hemispherectomy, but he had one of the most remarkable recoveries of all time, because he had so much damage from the stroke. He was having 200 to 300 seizures a day before surgery. So once his seizures stopped, he just returned to being a kid and being able to develop. And you can see how quickly he recovered, and just kind of went back home after 2 weeks after surgery, resumed normal therapies, and just went back to being normal Bennett. Here he is with his occupational therapist on the left and his physical therapist on the right, Barb, who's on the call today. Thanks for joining us. He did not do inpatient rehab. Some patients for the bigger surgeries will do that, but he did not need it again, I think, because there was just already so much damage. There wasn't a need to do. He already was dealing with the impacts of the motor impacts, et cetera, of the surgery. He started school on time and was had some school struggles, but was overall has been a pretty good student. He had a lot of sports and therapy kind of combined to deal with his cerebral palsy. And I'm often asked about what advice would I give to parents and clinicians. So the number one piece of advice I give to parents that are watching is that you know your child and you know when something is wrong, and you need to trust your gut. Push for a workup if you feel that what you're seeing could be epilepsy, and push for a surgical consult if your child has failed 2 or more meds, which I'll talk about at the end. For clinicians, I'd say trust the parents. They know their kids. Parents are not looking for something to be wrong with their children. If they see that something is wrong or different, it probably is. Both of my children have had a 1 in a million medical issue. My other son had a rare abdominal vascular condition. So assuming that because something is rare doesn't mean that the person sitting in front of you can't possibly have it. Dr. Hussein, who's a pediatric neurologist at UCLA, has said that infantile spasms are the worst form of epilepsy that exists. Children with infantile spasms face an incredibly high risk of other forms of epilepsy, like Lennox-Gastaut syndrome. They have a high risk of intellectual disability, autism, and a significant risk of SUDEP, sudden unexplained death due to unprovoked death in epilepsy. I have heard that every week that a child experiences infantile spasms, their IQ can drop by 4 points. Every anti-epileptic drug that is added also can reduce the child's IQ. Some of this can be recovered after surgery and once meds have been removed, but we still wonder what would life have been like for Bennett had he been diagnosed sooner and gotten to surgery sooner. Like I said, he had about a 2-year delay to surgery. This is what his brain looks like today. This is his brain on the left. He has a shunt, he's got hydrocephalus, he has a little bit of brain tissue left there on the right, but he's in college. This is him at his dorms when he moved in. He leads a fairly typical life. He has a lot of challenges, which mostly were present due to his stroke before surgery. He has CP, hemiplegic cerebral palsy, he has a visual impairment, he has a central auditory processing disorder. He does struggle with social and communication skills, and he has an autism diagnosis, but he has a very full and happy life. He's currently almost 20 years old. He's a sophomore in college. He volunteers at our local theater. He's interested in Special Olympics bowling and some other things. We know he's going to need some support throughout his life, but we do hope he'll work and have a family of his own someday. My experience with Bennett led me to become a patient and family advocate, and I'm really thrilled to work as the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance. We empower families with research, support services, impactful programs, and community. We are the only organization whose sole focus is serving the community of children anywhere on the epilepsy surgery journey, from the point of drug resistance through surgery, including the transition to adulthood and beyond. We have a biannual conference every 2 years, a family conference, which provides parents, caregivers, and siblings with information and community. These conferences have been an incredible opportunity for Bennett to meet others just like him, and I know many others have felt the same way. We also include clinicians and researchers to share their knowledge and meet the families, and some of them even conduct research at our conferences. It's also a really great experience for the siblings. This is my son, Sam, on the right, over 3 separate conferences with buddies that he met there, and so important for him to also connect with others. We also initiate and fund research. Our founder and executive director, Monica Jones, created and is the principal investigator of a global pediatric epilepsy surgery registry, which is intended to capture the developmental trajectory of patients after epilepsy surgery. In 2019, pictured here, we had a scientific meeting to begin to understand what the research says about motor, sensory, behavioral, medical, and cognitive challenges across the lifespan in patients who've had larger resections. And we invite all members of our community to contribute to our knowledge base: patients, families, clinicians, researchers, educators, and more. Here's a hemispherectomy patient, Colin, sharing his experience at that conference. We feel it's really important that families are educated about what drug-resistant epilepsy is and what their treatment options are. Drug-resistant epilepsy is considered after the patient has failed 2 appropriately provided drugs. But for a child like mine who had a stroke in utero, a massive lesion, he has what's called lesional epilepsy. Some centers are now saying they should only really have to fail 1 medication. And for a child who's had a massive stroke like my son and infantile spasms, it's possible that he shouldn't have had to fail any medication at all. There are a lot of barriers to epilepsy surgery, and part of what we're doing in our organization is to try to limit and eliminate those barriers altogether. Thank you so much for having me today. I'm going to hand it off now to Dr. Thibert.
So hi, my name's Ron Thibert. I'm a pediatric epileptologist at Mass General. I've been here, I guess, 17.5 years. So I'm a pediatric neurologist that specializes in epilepsy. But for the first maybe 6 or 7 years I was there, I also was the pediatric neurologist in the pediatric stroke clinic. So I was basically kind of keeping the chair warm for Dr. Mussolino until she was ready. But the kind of the reason why they wanted an epileptologist to be there until they could have a true stroke vascular trained neurologist was because that is a very common complication of stroke. So that's how I ended up there for several years, and now I'm mainly just kind of treat epilepsy all the time. So just a quick introduction, go over some some seizure types, kind of what to look for, what they mean, and then go through the evaluation a little bit, and then really spend more time on the treatments for seizures. So, so just kind of a quick introduction. When you think about perinatal stroke, so those are strokes that occur around the time of birth. You have acute onset and late onset seizures. The acute onset seizures, we don't really consider epilepsy. They're more of a symptom of the stroke. For children, teens, and adults, their seizures, pretty much always come later. There's a stroke, there's kind of an injury to that surrounding tissue that's still there, and then it kind of scars up, and the seizures come later. But for newborns, part of the symptoms of the stroke itself is to have seizures. And it's one of the big studies that we actually contributed data to back in the day. The Canadian Pediatric Ischemic Stroke Study had a good a stat that 88% of 88% of perinatal strokes, seizures are the presenting factor, and that's really true. That's by far the most common thing we see that gives us a clue that there's a stroke. Kind of the weakness, the asymmetry between the two sides, really doesn't show up for a few months later. So seizures is by far the most common symptom of that. So we usually treat those aggressively in the ICU, and then the babies will often go home without seizure meds because the risk of recurrence really isn't any higher than if they didn't have those. And then the late onset seizures are what we're going to talk more about. It's seizures that occur more than 7 days after birth, but typically much later than that. And these have a high risk of recurrence, so they're considered epileptic. One of the other big studies, and the rates really vary from, I think I saw from like 7 to 40%, but in this one large Swedish national registry, about a 24% rate of epilepsy in kids that had perinatal strokes. And then childhood strokes, basically from outside of the neonatal period of 28 days and less than 18, that's kind of considered childhood. These are much less common. The strokes themselves are much less common. Perinatal strokes are about 1 in 4,000. And that's really because of all the hypercoagulable, just the blood clotting easier, just the things that are associated with pregnancy. So all those factors will affect newborns. And then in children, it's only 1 or 2 per 100,000 as far as having strokes. So much less much fewer strokes in children past the neonatal period. And the rate was still fairly high. It was in that one study, it was 11.6 per 100 per 1,000 person years. So roughly like 11-12%. And just as a reference, epilepsy is the most common chronological or chronic neurological condition in childhood. About 0.5 to 1% of all children everywhere will have epilepsy. So it's really very common in kids, but as you can see, it's much more common if they've had a stroke. So I'll go into some seizure types. So the most common type of seizure following a stroke by far is focal seizures. And focal seizures are ones that start in one part of the brain. So depending where it is in the brain, that's what the symptoms you're going to have. If they're kind of in the central area, kind of like on the sides of the head, that's where your kind of movement center is. So you'll see kind of either shaking or stiffening of one arm. You can see the head or the eyes kind of go to one side. And then that kind of tells you that that's where that seizure is coming from. If they're in the back of the brain, you might get more visual kind of symptoms because that's where your vision center is. If it's in the temporal area, so kind of right above the ears, you can get some unusual symptoms like unexplained fear or smelling weird things that other people don't smell, or this kind of unusual feeling in your stomach that people really can't describe, but they all kind of discuss the same symptom. And these can occur at any age. Most commonly, we see them in early childhood when the brain's developing, more rapidly, or in adolescence. But there's also, a lot of changes to the brain, but also the effects of puberty and hormones really comes into play there. But again, by far the most common, and they can show up at any time. And then much less common, but much more urgent. And Audrey did an amazing job talking about it, is infantile spasms. So, you saw the videos of those already, the flexion of the arms, the head drops. when kids have head drop seizures, they're often a different type called atonic. But if you look at in those videos, you can see it. If the arms are also involved, if the arms aren't kind of dropping flat, if the arms are moving at all, then it's really much more consistent with a spasm. And those can often be missed because even epileptologists will see the head drop, think it's atonic. But if you really look closely and see the arms move a little bit, that puts it as more of a spasm. So as she mentioned, it's associated with a pattern, EEG pattern called hypsarrhythmia, which just means that the normal EEG waves are they're very tall, they're very unorganized, and there's a lot of abnormal little spikes, which are waves on the EEG that tell us that there's a risk of seizure. But there's extremely frequent spikes in all different parts of the brain. So with infantile spasms, the spasms themselves are very quick. As you saw, they're only a second or so each. The real risk of affecting development and like at that time and down the road is the very abnormal EEG pattern. That's what really requires urgent treatment. So studies have shown that the quicker you treat them, the better the overall outcome. And so really recognizing these quickly, getting them treated is super important. So that's but like as Audrey said, it's something that we really want to recognize quickly and treat. And that's just another slide of hypsarrhythmia. And I even kind of turned the amplitude down so that you could actually see it, and it's just kind of as is, like all the lines just run together. So it's very easy to spot once you see it. And then generalized seizures are less common, so I won't talk a lot about them. If kids have infantile spasms, especially if they're not fully treated or quickly treated, it can morph into more of like a Lennox-Gastaut type of epilepsy, where you can have absent seizures, which are kind of these longer staring spells, myoclonic seizures, which are quick jerks that are a little different from spasms, but it's more kind of twitchiness. Atonic seizures are when you just kind of drop, like you have a head drop, and unlike spasms where the arms can stiffen, like everything kind of just drops down, or tonic seizures where the whole body stiffens for a few seconds. So these can certainly occur, but typically if you're going to see them after a stroke or brain injury, they usually follow spasms versus just kind of showing up later. It's not impossible, but it's unlikely. So the focal seizures are by far the most common. Spasms are less common, but much more urgent to get in to see a neurologist or epileptologist. And then kind of going through the evaluation, one of the kind of in the last 15 years or however long it's been since cameras have been in phones, this has been like the most important thing that we ever tell anybody. If you can get a video of events and get them to your neurologist, it makes a world of difference in kind of diagnosing it. Like we'll see videos all the time, and for some we'll look and say, yeah, that clearly is not a seizure. For some, that's very clearly a seizure. And for anything in between, we just, like I said, we just bring them in and get an EEG and then know for sure. And so the video of the events is a great first step. But then if there's enough concern that they are seizures, we bring them in and get an EEG. These are just a couple examples of brain waves. This is an EEG of a focal seizure. So you can see it's just, and even if you don't know anything about reading EEGs, you can see this one little part of it is abnormal compared to the rest. And then for generalized seizures, it's when kind of all the parts of the brain are involved in the seizure at once. And so there's different kinds of EEG. The routine EEG is the one where you just kind of come in and you run it for an hour. And that, the benefits of that are that you can schedule them very quickly. They're short, but they only give you a snapshot of the electrical activity. So you know what's happening that hour, but it doesn't give you a complete picture. If you are having infantile spasms, like that short EEG will be enough to get to catch the hypsarrhythmia, but ideally, so as a screening test that can be helpful. But if that's there, then it's urgent that we admit and get the longer EEG, but also begin treatment. And the other types, so the other ones, there's as far as the longer EEGs, we can do them as an outpatient now. So with the pandemic, companies will go to the house. So they actually come to the house, they set the EEG up, they leave, they come back the next day, take it off. And 24 hours is great because it gives you lots of data while awake, lots of data asleep. Because sometimes abnormalities only show up in sleep. So if you just get an hour of EEG and they're awake the whole time, you could really be missing what's going on. And then the EMU, that's kind of the gold standard. Is just sometimes it's a little, especially this time of year where beds are scarce. Sometimes a little bit harder to get, but that's when we bring someone in and do video monitoring, and then you really get a good correlation of the EEG and what's happening on video at the same time. As I'll talk about later, that's what we do for our pre-surgical evaluations. But if the concern is spasms, ideally, if there's not an EMU kind of bed available, which is often the case, if you go to an ER of a bigger hospital, like Mass General, for instance, we can get the EEG in the ER, and if it's showing spasms, then we admit and start medicines right away. And then, of course, MRI. We want to get a sense of what the electrical activity looks like, but also is there a structural reason? And there are a lot of kids that will have strokes that aren't in the area, in the motor area, and if they don't have the seizures right at birth, and they don't have the problems with the movements on one side, strokes may go undiagnosed for years and years until there's a seizure, and then we get an MRI, and then we find it. So with any nuance at seizures, we do the EEG, and unless it's one of the very few kind of clear EEG patterns that we don't think are related to something structural, we always check an MRI, just because you can't find a stroke or anything else that might be there. And then, so getting more into the seizure treatments, the first line is typically medications. And for infantile spasms, there's two that are really first line above all others, as Audrey mentioned. The ACTH, or in some places they'll use oral steroids, but it's basically steroid medication. The other one is called Vigabatrin, or Sabril is the brand name. And several studies over the years have shown that these two are really are much more effective than any other medicine out there. And a more recent study that was from the pediatric, is called Pediatric Epilepsy Research Consortium. They did a study and showed that just kind of starting both at the same time even gives you that much better chance of stopping the spasms. And then there's medications that really treat only focal seizures and tonic-clonic seizures. So in kids that have strokes or brain injury, these are all options. The first two, phenobarbital and phenytoin or dilantin, we really rarely or perhaps never use these as an outpatient. These are the two medicines that we use most commonly in the NICU for those seizures that happen within a day or two of birth. They work really well, and then we stop them. And as far as medicines that we would use as an outpatient, Tegretol is rarely used in kids anymore. But the two newer ones, oxcarbazepine, eslicarbazepine, they're just kind of newer versions of carbamazepine that are have fewer side effects, are better tolerated. So these are really good medications for focal seizures and also tonic-clonic seizures. I forgot to mention earlier, when seizures can start focally in any part of the brain, but they can then spread. And if they end up spreading to the whole brain, that's when you get kind of the seizures that we all think of when we think of seizures, with kind of eyes rolled back, arms and legs kind of shaking, that we call those tonic-clonic seizures. So these medicines will treat focal and tonic-clonic seizures, which is going to be what most people, most children with strokes have. They have the focal type of seizures. But then there's also many more medicines that treat those type of seizures, plus the other ones that I talked about, the absence and the tonic and the atonic. So we call those broad spectrum anti-seizure medications. And the older ones, and I won't go into I don't have time to go into too much detail, but these are kind of the older medicines, Depakote, clonazepam or Klonopin, Felbutol, which we don't use very much, Topamax, Zonegran, Lamictal, Keppra. And out of these, the ones that are used most commonly are lamotrigine or Lamictal and levetiracetam or Keppra. The reason those are used are just because they're very safe, very easy. They have very few side effects. They're two of the medicines that have the least effects on cognition, which as Audrey also mentioned, that it's not just the seizures, but also the medicines can really kind of interfere with development at times. So those two are used most, and Keppra really is the most commonly used medicine in children in developing countries. Oops. And then so broad spectrum medications that again treat focal and generalized seizures, but are newer really since probably 2010 or more. Clobazam or Onfi is one that we use a lot. It's actually been around longer, but in Europe and Canada, finally we got it in the US around that time. But the other ones are all have also been very good. Vimpat and Banzel came out around that time. They're usually very well tolerated. Fycompa or Perampanel, same thing. Briviact, so levetiracetam is Keppra, brivaracetam is Briviact. The one thing with Keppra, it's super safe, super easy. You just kind of pee it out when you're done. You can go up on it really fast. The downside is about 1 out of 5 kids get really cranky on it. So Briviact is a newer version of Keppra, which has a much slower rate of crankiness. So for kids that were started on Keppra and it worked, but they were super cranky, they had to come off it. That's a really nice alternative. And then these 3 newer ones have been actually really promising. So Epidiolex is actually it's mainly just marijuana and sesame oil is what it is. What they do is they take out the THC, which gets you high, and it's just only the cannabinoids are left. And it's a medicine that works as well as the ones that came before it, but has very few side effects. So we've had a lot of good luck with that one. And then the 2 newer ones really just come out in the last year or two. Cenobamate or Xcopri is kind of a newer version of Felbutol, which came out in the 90s. With Felbutol, it can have pretty serious side effects to the liver, to the bone marrow. So it's not used much, but Cenobamate is a newer version of that where you don't have those worries. So you're not checking blood tests every week, then every month. And then Fintepla or fenfluramine is a newer medicine. It was actually part of the old diet drug Fen-Phen. So we have to do screening echocardiograms and that kind of thing, but it's really shown to be very safe for the heart and just very safe overall. And while most seizure medicines have about a 40% success rate in trials, the fenfluramine had a 70% success rate. So it's been the first medicine that's come out that's really kind of been noticeably more effective in trials than its predecessors. So like I said, these 2 medicines are very new, but they're very promising. And then other than medicines, so as Audrey mentioned, and I'll mention in a minute, after trying 2 anti-seizure medicines at pretty standard dosing, and that fails, that's when we start thinking about other options. So the 3 different options to treat seizures are medicine and surgery, and then diet therapy. So the classic diet therapy is the ketogenic diet. It's been used since the 1920s, but it goes back to I think like ancient Roman Greece. What they did back then was they would just starve people and they would seize less. So not a great option for doing that today. So what the ketogenic diet does is it mimics starvation. So when you don't eat anything, you just your brain uses the fat that's on your body. Your body burns the fat. Your brain uses it. So it's a very high fat diet that basically kind of forces the brain to use fat instead of sugar as its main source. And so the success rate is really high. It's 60 to 70% have very good outcomes, 90% seizure reduction. The downside is it's really hard. It's not just like no cupcakes or cookies or sweets. It's also no pasta, no bread. No, it's it's very restrictive. So kids that actually have feeding tubes, it's very easy. We just change the formula. And if you start it young, so kids that start at 18 months or 2 years of age, they just kind of grow up not kind of knowing what those foods taste like, so they don't really miss them. So it's tough for older kids, but it's still an option, and it's an option that is healthy. They're very healthy diets, and the side effects compared to medicines is much less, and just kind of. Yeah, so can tell with the 2 types that we use, the classic ketogenic diet and then the low glycemic index. Ketogenic diet is about 90% fat, whereas our low glycemic index, it was a diet that was first kind of put together for diabetes. It really it's meant to keep your blood and insulin levels nice and low and stable. But because of all that, also helps with seizures. So for keto, it's like I said, it's very high fat. For low glycemic, it's only 60 to 70% is fat, and instead of less than 10 carbs a day, you can have 40 to 60, but they're low glycemic carbs. So like a cookie it will raise your blood sugar a lot, whereas the sugar from an apple will only raise it a little bit. So you are getting carbs, but they're not really spiking your blood sugar so much. For keto, we have to admit to the hospital for 2 to 3 days. Low glycemic start as an outpatient. So basically the way we choose, basically, infants who are taking most of what they eat out of a bottle, and also kids with feeding tubes, we just go right to ketogenic. It's a little more powerful, but and it's really not any harder to do in those kids. But for kids that are older and eating by mouth and can make their choices, we start with low glycemic because it is less restrictive, and it's less potential for side effects as well. If you have too many fatty acids in your blood can become a little bit acidotic, and that can cause some tiredness. If it gets low enough, some vomiting. It puts you at risk for kidney stones. So it's something that we monitor very closely, which is why, like on these diets, you always want to be followed by a neurologist and a dietitian, because you can have some of those side effects, and people that the dietitians and doctors that follow you, they'll be screening for that constantly, and also will kind of know the signs and symptoms if they occur. And the efficacy for low glycemic is about 1/3 is either not effective or they just don't tolerate it. About 1/3 is a 50 to 90% reduction, and about the other third, about 90 or more % reduction. It can kick in about 2 weeks or less, or it can take a few months. But it is a nice alternative to medicine, especially for kids who just have side effects to lots of different medicines, and some kids are just prone to that more than others. And then so getting to the surgical options now. Children with strokes and brain injuries are good candidates for surgical treatments, mainly because we know that the seizure not coming from the whole brain, they're coming from mainly that one area where the injury or stroke occurred. So as Audrey mentioned, referral to an epileptologist is recommended after 2+ medications have failed. But I totally agree with what she said. If it's spasms, hypsarrhythmia, and then MRI shows a stroke, I would just refer right away. Doesn't mean you have to do surgery right away, but I would refer immediately. And because there's 3 types of surgeries: there's resective surgery, disconnection surgery, and neurostimulators. And just kind of talking about the pre-surgical evaluation, I think one of the big things that isn't always clear to people, and is probably one of the most important things to take away from this, is that seeing an epileptologist is, even like super early on, getting the pre-surgical evaluation, it doesn't mean you have to have the surgery. So when we see kids fail a couple of medicines, and especially if we know they have something on their MRI that's abnormal, or if they have spasms and we see that immediately, we like to refer. And then what the pre-surgical evaluation does, it just gathers a bunch of information. And then once that information is all gathered, what we do is we have these big conferences where it's several epilepsy specialists, neurologists, several neurosurgeons, a bunch of other people, and we go through all the data and we talk about it and kind of decide what we think the possible options are, which ones we think are the better options. And then we have a big discussion with the family and say, these are the potential options, these are the pluses and minuses. And then, then as a parent, you can either say, yes, that sounds good, we want to do this, or, we're not ready for this, we want to think about it. But it's really just important to have the information, have that option, to know it's there. And really with diet therapy too, like with any procedures that are at all refractory to medicine, we just want, it's important to make sure the families know they have medicines, diet, and surgery as options. And if surgery seems like a good option, then we really try to encourage an evaluation, because it's really just fact gathering. And then kind of you can make whatever decision you want based on those facts. But it's really nice to know, like, this has this % chance to work. These are the potential side effects, and then just having the information, you can make those decisions. And what the surgical evaluation comes down to is kind of like the initial seizure evaluation, EEG and MRI, but it's the longer, it's usually several days in the hospital. We try to capture several seizures on video, on EEG together. We have the MRI, it gives us kind of a picture of the brain. And then, but we also do some other and what we call functional imaging studies. So that's EEG and MRI. We do other things. One's called a PET. It's often known as positron emission topography. But what it is basically is that the kids have an IV, and we inject kind of a sugar that lights up, and so it goes in there, and we do this while we have the EEG leads on. If it's during a seizure, the part that's seizing is going to be more active, and it's going to take up more sugar, so it'll look brighter. If we do it when kids aren't seizing, and that's kind of the goal, is to get it when they're not seizing, the parts of the brain that are more likely to be having the seizures just aren't working as well. They're not using as much sugar, so they show up darker. So where the MRI is like just a true imaging study, just gives you a picture. This is more functional. It's imaging, but it's telling us like what parts of the brain are using more or less sugar, and is it during a seizure or not. And then the EEG stands for electroencephalogram. It measures the electrical activity inside the brain. The MEG, or the magnetoencephalogram, kind of does the same thing, but it measures the magnetic currents. So it's in an MRI, and instead of measuring the electrical currents, it measures the magnetic currents. And so it gives you the kind of the MRI picture plus these little dots are kind of where the discharges are. So it gives you a little bit more of a kind of a 3D picture of the brain. And in a pre-surgical evaluation, before you actually do anything more invasive, if a seizure focuses deeper down in the brain, sometimes it's not as easy to really pinpoint it just from electrodes that are on the scalp. So the magnetoencephalogram can give you kind of a more kind of 3D image of discharges that are deeper down. And then I didn't put in a picture of the SPECT scan, but the SPECT scan's another functional one, kind of like the PET. And with that one, it's just like this kind of bright tracer that we inject in, and we try to get it during a seizure and between seizures. So someone will actually sit there with the tracer and inject it once they see a seizure start, and then we compare the two. And what it does is basically just follows blood flow. When you seize, more blood goes to the area of the seizure. So if we get those scans during and between seizures, then kind of subtract them out, you can see what area is getting more blood flow during the seizure, and then that also helps pinpoint the area. And then once that's kind of all done, if everyone decides that surgery is the best way to go, there's two different methods. The one that's been around for much longer is, we call it like grids and strips, or subdural EEG, where a chunk of the skull is removed, and these, we call them grids. It's just kind of this little kind of mesh thing, but with all these different EEG electrodes. And so if all the other studies are showing us that the seizure looks like it's coming from this neighborhood, that grid can really help pinpoint, like, it's these two electrodes, or it's these two electrodes, and give us really specific information. They can also put in depth electrodes, which are electrodes that kind of go down deeper into the brain. And kind of along that line, a newer version, so stereo EEG, is it's less invasive. Instead of having to remove a big chunk of the skull, then put it back, just these little tiny holes are drilled into the skull, and these electrodes kind of come in through those little holes and down into the brain. And so that's a little bit, it's a newer technology, but it's less invasive. You can do it on both sides of the brain. With this, you can't do that on both. You can't remove parts of the skull and put that on both sides of the brain at the same time. So it lets you do like both halves of the brain if you need it. Kids with strokes or brain injuries typically don't need that kind of two sides of the brain. So it really depends on the MRI and the EEG and what it looks like. But either one of these would kind of be what would be recommended as the next step. Even if there's a clear kind of area of scar tissue in the brain, on MRI everyone thought, well, it's probably coming from there. To, in general, when there's a stroke and there's a bigger area of injury, we almost always would do these kind of more invasive EEG monitoring surgeries. So basically, and so what we do is we put in these electrodes, we record seizures while these are kind of inside or on top of the brain surface. And that just gives us super specific data. And then in the case of, well, either case, but especially in the case of the grids, they have to go back in and take the grids out anyway. So when they do that, that's typically when they'll resect tissue if the decision is that would be the right thing to do. And then so that's so resective surgeries are kind of the most common, the bread and butter of surgical treatments. Disconnection surgeries, Audrey did a great job of discussing it, so I won't go into too much detail. But if a big enough area of the that half of the brain is involved, and if the seizure is significant enough, so especially if there's hypsarrhythmia and it's not responding, a resective surgery really isn't going to be enough. So we actually do what's called a functional hemispherectomy or hemispherotomy, and basically what that is, in the old days they used to just kind of remove that whole half, but then you have the brain kind of floating around in this this kind of half-empty skull. So what they do now is that they'll remove smaller pieces, but basically they remove pieces that connect, like let's say in the left hemisphere, the parts of the brain that connect the left to the right will be either severed or removed. The corpus callosum is this thing here. This is the main connection between the two sides, but there's a couple others. So those connections to the other half of the brain are, like I said, they're either like cut or kind of removed. And then the other important thing is that they also kind of sever the connections from that side of the brain that goes down into the spinal cord and down, so that even if that half of the brain is continuing to just have seizure activity all the time, it's not going to the other half and it's not going to the body. So it just doesn't affect the child anymore. So these kind of functional hemispherectomies, where that part of abnormal brain is kind of left in, but just disconnected. That's kind of more the norm these days. And it sounds like a crazy thing to do, but really kids recover very, it's amazing how resilient kids are and how they can recover. One of the kids that we have here that went through the hemispherectomy, it's he had it was a perinatal stroke, same thing, hypsarrhythmia on the one side. But what really kind of sticks out about some of these things, you'd think that, say it was the right side of the brain affecting the left arm and the left leg, you would think that removing that part of the brain would make things worse, but it actually made it better. So when babies or when kids have strokes, it just happens more so the younger you are, the kind of the functions that would have been on that side transfer over to the other side. So for a lot of these kids, that function's already kind of transferred over. So basically what you're doing is you're removing part of the brain that's not helping in any way, and it's just causing problems. And by removing that area that's causing seizure and affecting the other side, that other side can then be healthier and more effective. And so like for this boy, like his left arm and leg got stronger after we kind of disconnected his right half of his brain. And Audrey made a great point that, the kind of the thought of removing brain seems like you're really, causing problems, but the parts of the brain that are seizing, they're not helping. They're not really doing anything. They're injured, they're damaged, and they're causing seizures, but they're not really doing what they're supposed to be doing. So by removing them, things actually get better. They don't get worse. And in for kids that don't have spasms, are just kind of the classic focal seizures. And you think about resection, if they are kind of in a sensitive area like language or motor, and the thought is that resection could cause more problems. The other option is neurostimulators. There's two different ones. One is we're called the VNS, the vagal nerve stimulator. So it's this one. It's a little device that implants in the chest wall, and then it wraps around this nerve, the vagus nerve, which kind of goes from the brain down to the heart and lungs and gut. It's always on the left because the left side is the one that mainly goes up to the brain. The right side mainly goes down. So what it does is it sends an electrical impulse, and then that impulse, the theory is it goes up to like the relay center in the brain, and then it can disrupt the seizure network. So just kind of that electrical pulse can kind of stop the normal brain cells from talking to each other and creating seizures. So it kind of does that on a schedule that you set, and you can go up on the strength of the current. You can kind of make them happen more frequently for less time. But also has the option of swiping a magnet over it and then setting off. So if a seizure starts, you can swipe the magnet and set off like a current that's stronger and longer than the typical. And then the new one, the RNS, or responsive neurostimulation, it's implanted in the brain. And the nice thing about that is it's it has two different electrodes that you can place on the area where the seizures are coming from. So if it's an area that you can't resect, you can put the RNS in, put the leads on there, and really target your stimulation to that one area. The other nice thing about the RNS is that it's programmed to recognize your seizure when it starts. So it's constantly recording EEG data. So you can actually use it to really look and see what's been going on the EEG in that neighborhood. And also, as soon as the device recognizes the EEG pattern coming, it'll send an extra pulse. So these aren't curative, but for kids that have tried medicines, tried diet, haven't had a ton of success. About 50% or more of the people that get these stimulators have a 50% more reduction in seizures. So it can really, if resection is not thought to be, or disconnection are not thought to be good options, this is one more surgical option where you're not kind of removing or disconnecting anything, but you can still improve seizures through surgery. And I think I'm kind of over, yeah. So I might have gone a little over 25 minutes, but it was a lot to get into a short time. So that was all I had. Didn't know if there were questions. Is that what's next, the question?
Was great, Ron. Yes, I think there's a bunch of questions in the chat that Mara will help us moderate. And as everyone can see, every case when we are having to deal with particularly injury-related epilepsy is a very particular case on its own. And there are multiple options, there are multiple assessments. There are very many differences depending on when the injury happened, where the injury happened, and what is it looking like in terms of the seizure type. So I would encourage everyone to also think about any of the answers and don't apply anything as a blanket, guys. The idea here is that we can see there are many, many complexities on this and the assessments, but also in the treatment options, and that you should know about them so you can ask questions. And if you don't get your answers, you look for someone that can answer the other questions, and don't stop until you can have those questions answered. So I'm gonna pass it on to Mara to moderate the questions, Ron and Audrey, and I see, Audrey, you've been answering some of them on the chat, which is awesome, with resources and everything. So
I'm a bit of an information junkie, so I'm sorry if I'm overwhelming you with complex information, but I did put my email also in the chat, and I'll put it in again. Anyone can reach out to me at any time, and I can have a conversation and talk you through any of these. I'm not a doctor, so I would be just helping you frame questions and who to talk to and what to ask.
Thanks so much, Audrey and Ron and Patty, for teeing us up. So I'm gonna invite the community field. If you're able to come on camera and ask your questions, it really helps build a sense of community. I have the sequence of questions, and if I miss you, raise your hand electronically or live, and I'll see you. So Paul had asked a question first. Do you want to come on? It was, I think, about the cannabis medication. Hi, Paul.
Sorry. Hi. Yeah, I just had a quick question about substitutes for clobazam. I know that this is focused on surgery, but I was just interested. I've heard that the CBD oil medicine could be a suitable substitute for like Lennox-Gastaut seizures. And I was just wondering, if anybody had input on that, or specifically if Dr. Thibert could speak to that.
Yeah, no, it's a really good medicine. So for Lennox-Gastaut syndrome, really it's those broad spectrum medicines that I was talking about. And the Epidiolex is what we've found is it's had really good like a really good side effect profiles. So it's not just, of course we want to do the medicines that work, but also if there's several options that might work, we kind of start with the ones that have the less potential for side effect. And that's one of the things that's really stood out. The effectiveness has been about the same as a clobazam or a Keppra, but it's been really well tolerated in kids. And so it's the one downside is it comes in an oil. Some kids hate that. And it can make if you're constipated, it's great. It helps with that. But if you're not constipated, it can make that a little bit. You just drink a lot of oil. But it's but it's been a really good medicine for us. And actually combined with clobazam, they work really well together. The Epidiolex will increase clobazam levels. So if you start it and you're on the clobazam, it's going to make you too tired. But a small dose of clobazam with the Epidiolex can really kind of enhance it even a little bit more. But it's really good medicine for really all types of seizures. And I know the one thing people are probably thinking, like if you want to travel with it or whatever, it's actually not controlled. So when you get clobazam or Valium, it's a controlled medicine. The Epidiolex, even though it's made from marijuana, is not a controlled substance anymore. So there's no worry about like having marijuana. It's not even a controlled substance anymore.
Thanks. I just want to clarify that we're really talking about epilepsy in general and not only surgical approaches.
Yeah.
We always start these educational sessions with a case study. The case study today happened to involve a hemispherectomy, but as you heard from Dr. Thibert's presentation, it's really spanning all the treatment options. And so we really want this Q&A to also reflect all the full spectrum of what the treatment options are. So just reiterate that. Miriam, good to see you. And I saw you have a couple questions.
Yeah, thanks, Mara. It's so good to see you too. Yeah, so, my son didn't have a stroke. He had a TBI. He was hit by a car and had a severe traumatic brain injury with diffuse axonal injury. So I'm wondering, the question I posed was, are there benefits to following a modified Atkins or a low glycemic diet for someone who's already on 2 anti-seizure meds? Does the diet, are you trying to do the diet to get off of the seizure meds, or does he not need to worry about the diet because he's already on the seizure meds? And then also, is it different when your brain injury is caused by stroke versus, impact?
Yep, it's a great question. So for the second question, not really. Kind of injured brain is injured brain. So whether it's a stroke or a traumatic brain injury or bleeding, it's still kind of injured brain cells that are causing the seizures. But as far as diet therapy, so kind of the two goals for diet therapy, one is to stop the seizures. So if seizures are not, so the two kind of main times we use it are when seizures aren't controlled well with a couple of medicines or more, or if seizures are controlled well, but there's a lot of side effects, and no matter what you try, you're getting side effects. So you can either add diet to the mix, to really just try to get the seizures under better control, or, for someone who's already well controlled, you can try to add that in to get off medicines. And even in the first scenario where you're trying to just control seizures better, if the diet really works and seizures do get better, then we typically do try to cut back the medicines if we can. But for people that are not well controlled, it's a great option. And for people that are, but do have some side effects from the medicine, it can also be a good option, because if you can use that to get you off the medicines, then you can remove the side effects as well.
Thanks.
And Miriam, did you have another question about neuromodulation?
Oh, about neuromodulation. Yeah, just so when he did his rehab at Spalding, which is how I met Mara. And so I was really interested in the neuromodulation techniques that they were using there to treat focal seizures. And so I was just wondering if you could talk, you talked a little bit about the neurostimulation after I had put that question in the chat, but that seemed really interesting and promising and non-invasive.
Yeah, it's are you talking about the VNS RNS specifically, or which?
Pardon?
Oh, were you talking about the VNS and RNS specifically, or?
No, just the. I mean, I don't really think I have a question there because I think you talked about it after I put it in the chat.
Yeah, but just like as a like on a bigger picture level, the you know, the neuromodulation techniques are just they're really nice to have as another alternative, because not everyone's a good candidate to have something removed or disconnected. So in those cases, it just gives you another kind of non-drug option, but also non-diet option that you know, and very few people have side effects from them. It's not impossible, but they're usually really well tolerated.
And I'll add, Ron, in the acute setting, right now, neurocritical care units, which are mostly deploying these technologies in adults, but it's coming to kids too. We do use for focal seizures in acute TMS at the bedside to try to quiet down those areas. And it applies to many of the patients that we have with focal injury, like traumatic brain injury. Sometimes the place where contusion is, it starts seizing, and the patients are awake, but they can't stop seizing from that part of the brain. So they're coming along. So I think there's going to be more in the next few years of chronic management of focal epilepsy, but it has to have, as everything we were discussing, the really right combination. It has to be superficial. It has to be connected to an area that you do not get a deficit if you quiet down, because the effects may not be just at the moment you're doing the TMS, the transmagnetic stimulation, but lasting. And again, you need to make sure that you're not in an area of what we call eloquent brain. And that's where Ron was talking about. These evaluations are very lengthy to try to not just map where the seizure focus is coming from, if there is one, but also what areas are used in the brain for function, like speech or motor, that you don't want to be silencing, you don't want to be zapping with your electrode, you don't want to be doing surgery on, because it will lead to a deficit. And sometimes we pick the deficit because the seizures are so disabling, the kids cannot be awake. And then we do pick having to take a deficit as a consequence of controlling the seizures. But that's because the seizures themselves are so much worse outcome than losing one function or one part of the function of the brain.
Tough choices.
Mm-hmm.
Okay, I'm gonna answer a question that was asked to me privately. So this whole session is recorded, as with all of our sessions, and will be on our YouTube channel within a week or so. Given Thanksgiving, it may be a little longer. And also, if we can get the slides from the speakers as PDFs, we could also put those up on our website, because there's a lot of interest in the particular lists of interventions, I know. And then, Lauren, are you still here?
Yes, I am. Can you hear me okay?
Yep.
In a large space here. Yeah, I had a couple questions. And so my son had a pre-birth stroke, and he didn't start taking epilepsy meds until he was about 6, Keppra, and it worked for several years very well to control his seizures. He had a couple breakthroughs. And then they came back 2020, so he was about almost 10, and they really haven't subsided since, and he's 14. And so we added to the Keppra another medication called, well, the Onfi, which really didn't work that well and had some undesirable side effects. And then we switched the Onfi for Vimpat, which has been working very well, but it has some unfortunate, sort of more psychological side effects. So he's basically on his 3rd med. And I know that all along the epilepsy doctor that we've been seeing has said, like, surgery, you should really need to consider surgery as an option. And we've always just, it's been very scary for us to consider that, because the data seems to suggest that, like, the surgery itself is very risky, of course. And then the outcomes are not necessarily, like, the success rate isn't exactly, like, encouraging. I mean, I love hearing the stories of the kids who get complete seizure freedom. I'm just so worried about, like, what's going to happen on the operating table, and then what's going to happen, like, is it going to work if I'm going to put my kid through this now that he's 14? So I'm kind of concerned about now that he's older, what are the what are the risks that we're looking at other than, of course, like all these years where he's had the breakthrough seizures and all the things that he may have lost through that. Just the surgery itself. And I guess bouncing back might be a lot harder now that his brain would have to sort of like rewire, and just now that he's older. I don't know.
I respond to the surgical risks and the medication and the success rate, and then I'll let the doctors jump in.
Okay,
So
thank
this
you.
was just at Epilepsy Awareness Day at Disneyland. We just did all the surgical, we invited all the surgeons to speak. And several surgeons said the idea of the risk of surgery is inflated in people's minds. The death rate is about 0.5% to 1%, depending on the center. And then the adverse outcomes rate is somewhere between 1% and 2%. So it's very, very, very low. And depends on the surgery, depends on the situation. I mean, this is a very broad statement. And then for the risk of success of surgery, and again, this varies very much by surgery. After the second med fails, the odds of a third med working is less than 4%, and it drops from there. Most surgeries, especially for lesional epilepsy, have a 50% or greater chance of stopping epilepsy or significantly reducing epilepsy and providing like what we call palliative. And people think that's end of life, but all it means, you're on palliative treatment right now if your meds aren't working, right? So quality of life can be improved. And then there's new research, and I shared the link in the chat, that shows that patients who have drug-resistant epilepsy have a higher risk of mortality. If they are treated with a VNS, that risk is reduced by 30%. If they're treated with a craniotomy and meds, their risk of mortality across the lifespan is reduced by 83%. So there's a blog post and a link to the paper that you can read. I'm happy to talk to you, happy to hear what the doctors have to say, but I just wanted to put that out there.
A very big differentiation here. Lennox-Gastaut encephalopathy is not the same as refractory epilepsy, guys. And the paper that was cited in the chat is just referring to Lennox-Gastaut. In fact, it's published in a low-impact journal with information that is partial, guys. And that happens with pediatrics. It's not the fault of the doctors that were publishing the paper. Is that we don't have large studies to say and compare them side to side. I studied 340 patients with epilepsy surgery to the teeth when I was a pediatric pediatric resident. We could only conclude that the ones that had those outcomes that we are talking about, like resolution 50%, are the ones that in the previous evaluation, which requires a surgery, have a very focal onset of seizures, and were very disabled by frequency of the seizures, not just from the seizing, but from the cognitive impact of the seizures. So I wanna a little bit, and Ron, you can probably with much more authority than mine, than the acute management person, the stroke, and I do happen to have a research inspect on epilepsy surgery, and I spent several months in the OR, but you do this every day. I do want to separate refractory epilepsy, which is a failure to medications, which is, we see it all the time, and mostly in pediatric stroke kids, which you end up many times, and I was more than half of the time, finding a drug that does control. And not only that, development alone, guys, changes your connectivity. And a lot of our kids with epilepsy that are not cognitively disabled, that are not Lennox-Gastaut, which is what this paper is referring to, end up outgrowing a significant burden of their seizures once they finish their development. So we see a kind of a surge of epilepsy, and then there is very limited data on the adults that have been followed long-term. Most of the studies do not have adult data. So we don't even know what is happening after you graduate your development of the brain with these epileptic focal seizures. And I'm just trying to narrow it down to epilepsy in the setting of brain injury, focal brain injury. So a lot to be taken into consideration when you're making a statements of 50% or 1% or whatever. Guys, the data is very, very limited and skewed by the population that is being studied in every study. So we all at fault on that because we claim those titles and those statements and those conclusions. But if you take it in a full context, it's a lot more complex. That's my contribution. So for a lot of our patients with Ron, where we see a drug that worked and it stops working, it's usually not the injury to the brain, it's just development. like development is changing, the brain connectivity is changing. There is a lot of hormonal changes with puberty, and sometimes it's switching meds until we can manage that period. And in 2 years, we are in a different patient. And surgery would have been great, maybe, but it wasn't indicated because they kind of grow, but developmentally they're challenged. And just putting that in particular for the patients with focal injury. And Ron, I don't know, you have other insights from your experience on working with all kinds of epilepsy, like
Yeah.
more.
No, absolutely, yeah, and that's so that's so kind of thinking about what the question was. That's actually kind of why we do those big pre-surgical evaluations. So even if it sounds scary, you know, doing the evaluation and getting the info, if at the end of the day the thought is, you know, we don't have a great chance of finding the exact spot that's seizing, there are some risks. The medicines there's still several medicines that can work. You know, we might just say like, we don't recommend surgery at this time. So it's the nice thing about getting the evaluation is just to get getting all that info and putting it together. And sometimes we say, yeah, we really recommend the surgery because we think it could stop your seizures and be life-changing. And sometimes we say, yeah, like things are good enough right now that, you know, the risks don't outweigh the benefits. So, and every kid is so different. I think it's good just to get that data on that particular child and then make that decision.
Yeah, that's the best answer, Ron. Go and get an evaluation.
Yeah.
And go with a team that can do
evaluation.
epilepsy surgery or offer you the devices. Because if they don't have it as options, then the evaluation will be limited to what they can offer. Nobody tries to do deep electrodes if they don't have a surgical team, guys. So or mapping functional connectivity if they are not planning for an assessment of epilepsy surgery. So I think that's, for anything, is try to get a full evaluation. That will be the best answer.
I think that's all I was trying to say. And I was referring to the paper about mortality, actually, the 2023 paper, which was published in the Lancet and had a pretty comprehensive team. I know it was a review article, but our thinking in our organization is just to get families to the referral. So surgery is your decision as a family, and there are so many variables. But if you don't have all the tools in your toolbox and you're not being told about options, it would be like if you had cancer and they said, we're going to offer chemo and radiation. And you said, well, what about removing the tumor? Oh, no, we're not talking about that. So it's just important that you have all the information on the table. You might decide the risks are too great or that the benefits are too low. And that's your choice. And you and your doctor have to decide that, but not going because you think that the mortality rate is 50%, or you think the odds of anything helping is so low, it's not worth it. Until you go through the workup, you don't know. What you won't know. You have to follow the breadcrumbs until you get those questions answered. And we can't answer them here on this webinar. You really need, like Ron was saying, that detailed pre-surgical workup. Our Let's Talk About Epilepsy Surgery series talks about every step in that process. You can watch that and see, well, you know, would I want to go through this? And not every test is for every patient, but they can give you a lot of information. Some patients go through a surgical referral and workup and don't have surgery, and they still have improved outcomes because the epilepsy is better understood. So it's not about getting surgery, it's about getting the evaluation. And agree with Dr. Mussolini that it has to be a team that knows what they're doing and can do it. So.
And actually getting the information, like you still could be scared of the surgery, but you'll be less, like having that information is actually less scary than more scary, because when you're kind of wondering what surgery might be, you can think of all these different things in your head and imagine all these awful outcomes, but then the actual information itself will help. And you still could decide it's too scary, we don't want to do it, but at least like knowing versus not knowing, it actually is less scary. And kind of the other potato, the reason that I did the whole thing about the surgical evaluation, but also listed like all the 20 medicines. It's also it's just good to know what's out there. And there's always new medicines. There's always different surgeries. There's always, you know, different diets, so that there's, you know, you should really never come to the point where someone says, well, we're kind of out of options, because there's always more options. There's always things you can do. So if someone ever tells you like, well, there's nothing else we can do, then you need to find someone else.
So I have a question for both of you guys, is where does a family that not necessarily lives in near an academic center that has an epilepsy team, like a comprehensive epilepsy management team, can go or find information on what are these centers? Is there Epilepsy Society has a list of centers that have comprehensive. So I give you an example for stroke care. We have comprehensive stroke care certification from several, including Joint Commission. So you can look them up and you can see if you have a stroke, you can look at what are the comprehensive stroke centers in the country. I'm saying this because not everybody lives in nearby a place or knows where to go. Is there a place where you can guide people to where to find these institutions or these teams?
Ron, do you have an answer? If not, I'll answer.
Yeah, I don't know for sure, but the Epilepsy Foundation of America website usually has that kind of information. But if Audrey, if you know specific places.
So there is something called the National Association of Epilepsy Centers, the NAEC. They do give, it's not really a certification, but you can be designated as a level 3 or level 4 epilepsy center. Unfortunately, we have seen level 4 epilepsy centers, for example, that have only, that don't even have an epileptologist. So there's certain criteria, but sometimes with staffing changes, you might end up at a center where at that particular moment in time, they don't actually meet the qualifications, but they still have their level 4 certification. There is no guidelines like you described, Patty. That's actually something we're working on in our organization.
That's what I was gonna, yeah.
Guidelines for that there have to be specific requirements for centers. If you can always reach out to our organization. That's our mission, is to help connect you with resources in your city, state, wherever. We also have a Pediatric Epilepsy Surgery scholarship. If you have to travel more than 50 miles from your home to go to a level 4 epilepsy center, we'll pay $1,000 in travel expenses for you to get to that surgical first, second, or third evaluation, because we think it's so important, again, for that evaluation to take place. That could be covering hotel, gas, air flights, whatever it is that you need to get there. That's all on our website. epilepsysurgeryalliance.org. And again, the family can just reach directly out to me. We know a lot of the surgeons really well and a lot of the centers really well. So we could tell you, yeah, in this area, I know that here are 3 level 4 epilepsy centers. This one in particular seems to have a team that's really well versed in LGS or Dravet, or this team really knows tuberous sclerosis, or this team is the Rasmussen's team, or whatever it is that the underlying condition is. But we can't recommend a particular center because it's just not in our, it's just not something we can do. But we can certainly tell you about this is what we know, but we are working on getting those guidelines for epilepsy surgery centers and epilepsy surgery care, which don't exist yet, which is really pretty shocking. So yeah, it's very difficult. But again, that's why we're here. I'm less of the medical person. Honestly, I was here for the patient story. My boss, Monica Jones, is published in the journals and runs our Global Pediatric Epilepsy Surgery Registry and is connected with all the surgeons. She usually takes those questions from families when it's more of a, what should I be doing next? And we have a list of questions on our website. We have a lot of information. So yeah.
Yeah, fantastic. This is exactly what I was going. I put the 2 links in the chat too, for the one that you just refer, Audrey,
Yeah.
plus the Epilepsy Foundation. So people can orient themselves also if necessary, and whomever is watching this video later on, in live mode to this. So the idea is to really do this, is connecting people, is to let them know there are many options, that the evaluations are complex, but required to have the right team. If not, the questions are not asked correctly, and then you never get the full ability to really try to control the seizures, which at the end of the day is the goal, to allow the brain to develop to the fullest. So I'm very glad.
One thing too is my son had the biggest epilepsy surgery you can have. You can't take out more than half the brain. We do have some families in our community that have had a hemispherectomy and then have gone on to neurostimulation or VNS because the child continues to have seizures for whatever reason. So there's more that you can do even after a hemispherectomy. I'm not saying that you have to stop there, but most patients with lesional epilepsy, they can be treated with a much smaller resection or a laser ablation or possibly neuromodulation, in addition to diet, medication, even lifestyle changes, right? So there's lots of ways to manage epilepsy well, right? That you can look up the MEW, the Managing Epilepsy Well Network, has lots of guidance on that. So I don't want people to think, oh, hemispherectomy is the only type of epilepsy surgery. That's the most extreme type. So I have a friend who, her daughter had seizures for 10 years. They did a SIG when she was about 12, subdural EEG, and they said, nope, we can't find anything, no. And at 17, they went back and did another SIG at another center. They found a spot. She had a pinpoint laser ablation. They literally put a Band-Aid on the spot, and she went home the next day, and she has not seized since, and that was 6 years ago. So it is possible for there to be very minor surgeries. And again, like with LGS or Dravet or something that's much more complex, that's much less likely. And what Ron said too, like I hear this from the surgeons when they speak all the time. Anyone who tells you we can't do anything, I would just say, wait a year, wait 5 years, because the landscape is changing so dramatically in the neuromodulation world and other treatment options. Not so much in medications, but even for LGS, there's a new medication that came out in recent years. So there's always hope to find at least a treatment solution to improve the quality of life, if not to cure the epilepsy.
I'll shorten it to 2 every 2 years.
2 years.
2 years.
Well, that's why I said wait a year or 5 years, whatever it is going to be. But we're going to see the doctors, when they spoke this year at our conference, they said, my entire talk is different than it was 3 years ago because of all the advances in the neuromodulation. They had to add, and that's a lot of what we're sharing on our YouTube channel and stuff is those talks, because people are very interested in that. So.
And I think the field of also the underlying cause, when it's not necessarily chest focal injury or it's focal injury plus, with all the genetic evaluations and causes of, and the understanding of mechanisms, and now we are going to targeted therapies. That's why I said the 2 years, because we are mapping much better what is the disorder underneath, and options will become available even with drugs that are currently approved that are more targeting those pathways that have been disrupted. So
when my son, go ahead.
Oh, I was gonna just add on that. Just thinking about genetic, like if you think about kids with either autism or developmental delays with epilepsy, like back when I was a resident, which wasn't like that long ago, really. It wasn't like the 1900s. It was like in the like 03 to 06, it was like we could pick up like 7% of the genetic causes of autism, developmental delays, and epilepsy, and now it's more like 35, somewhere in that neighborhood. So just in the last 15 years or 15 to 20 years, it's really like just shot up the what we can do genetically, and I'm sure it's just going to keep going.
Thank you so much, both Audrey and Dr. Thibert. And we are honored to continue to have excellent speakers for our sessions. The next planned session is in January for summer camps and all the considerations that you might think about as you're wondering how to fill your children's summers in a fun and therapeutic way. And we'll be in touch with a survey soon about today's session, and also what you'd like to see in the future. So thanks again, and have a great afternoon.